Hello everyone, the following presentation will be over proximal humeral fractures and it will be presented to you by physical therapy students Lisa Elliott, Anna Harpst, Elaine Tsai, and Justin Walker from the DPT class of 2014 at Texas State University. Here we have an overview of what will be addressed during our presentation. A proximal humeral fracture is defined as a fracture of the humerus close to the glenohumeral articulation involving the humeral head, the greater tubercle, the lesser tubercle, and/or the diaphysis. For an interesting tidbit of history, the first humeral fracture was documented by Hippocrates in 460 BC and it was treated with traction. Other early treatments of such fractures also consisted of closed reduction, casting, and abduction splints. The first surgical procedures gained popularity in the early 1930s. The most common mechanism of injury is falling on an outstretched arm. Other MOIs include strong muscle contractions during seizures, sports injuries, electrical shock, or a direct blow to the proximal humerus. High-energy trauma is a more common MOI in younger patients. Individuals at risk for these fractures are those of older age, osteoporotic, and those who tend to be a little clumsy. Proximal humerus fractures make up about 5% of all fractures, but this is most likely a conservative estimate. As the average lifespan increases and as the baby boomers are reaching older age, the incidence of proximal humerus fractures is expected to increase.
The patient can present with pain and swelling of the involved shoulder and upper arm, as well as paresthesia and weakness of the involved extremity. Bruising typically develops 24 to 48 hours post-injury. There's also a possibility of open wounds. Observation, palpation, and a thorough patient medical history should be included in the clinical examination. Info that is needed that will affect treatment choice includes mechanism of injury, time span since the injury, patient age, overall health and fitness, and any comorbidities. Possible associated injuries include vascular lesion, neurovascular injury, or pneumothorax.
With imaging of the proximal humerus, there are many options to choose from, but the two primary views that are obtained are the anterior-posterior view and the scapulolateral view. The AP view gives good visualization of the greater tuberosity. The scapulolateral view, also known as the Y view, is an image to confirm if there is a dislocation from the AP view. The axillary view is the best true lateral view of the shoulder. It allows evaluation of head compression or glenoid fractures, dislocation or subluxation, but the drawback is it must be obtained with the arm abducted, which in acute patients could be hard. The wheelchair axillary view allows the glenohumeral joint to be assessed with the arm at the side, which benefits a recent trauma patient that doesn't need to be abducted. Another option is CT, which uses x-rays to create cross-sectional pictures of the shoulder. There continues to be research to this day trying to come up with a better classification technique for proximal humeral fractures, but the inter-rater reliability in those studies continues to be inadequate or more valid than the NIRS classification. NIRS classification was developed in 1970, but it is still relevant today to be the best way of classifying proximal humeral fractures. The proximal humerus is made up of 4 different parts, and each injury is affected differently. Naming becomes difficult because 2 levels are frequently involved. A classification named solely on the level doesn't take into account the severity of the particular fracture. That is why NIRS classification is still a good tool today because it names the fracture to the level of displacement and also takes into account whether there are 2, 3, or 4 parts involved. This slide shows NIRS anatomical classification. For level 1 is minimal displacement, includes all fractures in which no segment is displaced more than 1 centimeter or is angulated more than 45 degrees. For level 2, it's at the anatomical neck. This is a relatively rare injury in which there's displacement to the anatomical neck, but there is no separation of either or both tuberosities. For level 3, it's at the surgical neck. Level 3 fractures occur just distal to the tuberosities and is displaced more than 1 centimeter or is angulated more than 45 degrees. One thing to remember in level 2 and level 3 is the rotator cuff is still intact. Level 4 is at the greater tuberosity. This level is where we start getting 3 and 4 part fractures with longitudinal tears and rotator cuff. With the greater tuberosity retracted and displaced, the subscap, which is attached to the lesser tuberosity, causes the articular segment to face posteriorly due to an internally rotated humerus with no co-contraction of the rotator cuff. For level 5, it's at the lesser tuberosity. This occurs oppositely to the greater tuberosity fracture, in which, depending on the injury, could cause an externally rotated and abducted humerus due to the natural pull of the external rotators and the supraspinatus without the co-contraction of the subscap. Level 6 is a fracture dislocation. The fracture dislocation level 6 injury occurs with a true dislocation, which denotes ligamentous damage and injury outside the joint. The displacement can occur in any direction, but as long as the injury isn't a 4-part injury, the humeral head can receive adequate blood flow to the redundancy of the anterior and posterior circumflex humeral arteries. So for treatment of proximal humeral fractures, you have 2 choices: conservative or surgical treatment. Conservative treatment is reserved for fractures that are non-displaced or minimally displaced, and surgical treatment reserved for those who have displaced fractures. So for conservative treatment, you want to immobilize for 10 to 14 days. Handel et al. Systematic review found that using a sling was better than using a bandage, and you also want to do active range of motion in your distal joints to prevent any stiffness. After the 10 to 14 days, you can start adding gentle passive range of motion and progress with the classical near regimen, which will be covered in detail in the next couple of slides, and this resulted in less pain and a potential for better recovery. On this slide, you will see different surgical options that you can choose. You can use external fixation, internal fixation, closed or open reduction, hemiarthroplasties, or total shoulder replacements. For 2-part fractures, sources suggest using an ORIF and it's reinforced with either sutures with eyeleted nails, tension band wiring, intramedullary nails, plates, or screws. For 3-part fractures, they suggest using ORIF or a hemiarthroplasty in those with osteoporosis or in the elderly with complete loss of soft tissue attachments. For 4-part fractures, they suggest using a hemiarthroplasty, and this is due to a high failure rate with ORIFs due to avascular necrosis or non-union, and a hemiarthroplasty can also be used if non-union occurs with the first surgical procedure. So for post-op management, sources suggest using the classical near regimen, which can be started 2 to 3 days after surgery. It consists of 3 different phases. Phase 1 includes passive range of motion, pendulums, assisted forward flexion and external rotation in supine, and the use of pulleys. Note that the pulleys are not to be used with tuberosity fractures until 6 weeks post-op due to the attachment site of the infra and supraspinatus. These exercises are to be repeated 4 times a day after initial warm-up with a heat pack, and it can be deferred 2 to 3 weeks if you are concerned with the stabilization of the fixation. So for phase 2, which is approximately 6 to 12 weeks post-op, you want to do active, resisted, and stretching exercises, and this includes active forward flexion, internal and external rotation with a TheraBand, and doorway stretching. For phase 3, which is approximately 3 months post-op, you want to increase your resistance with the use of weights with a maximum of 5 pounds, and you want to continue your stretching. Your goal is to reach a functional gain plateau or pre-injury functional levels. Post-op complications include neurovascular injuries, chest injuries, frozen shoulders, avascular necrosis, fracture non-union, or fracture malunion.
2 common outcome measures used with this patient population are the constant Murley shoulder outcome score and the DASH or quick dash.
There are multiple factors affecting your outcomes. So it's either classification of the fracture and the fracture type, your mechanism of injury, so high versus low energy force and indirect versus direct forces, patient compliance, medical comorbidities, and time span from injury to treatment or surgery.
When it all comes down to it, treatment for proximal humeral fractures still remains controversial. Conservative treatment and post-op treatment depend on multiple factors including age of the patient, bone mineral density and health, surgical procedure used, comorbidities, and pre-injury functional status. Before proceeding with exercise, it is important to know the healing process of bone and soft tissue in order to prevent further complications.
Here's a list of our references. We hope you've enjoyed our presentation. Thank you and enjoy your day.